first. So, in a gist, heart failure is going to be some sort of dysfunction that is leading to an issue with our heart pumping the way that it's supposed to. Okay. So, this is going to lead up to impaired cardiac output and impaired tissue perfusion. Okay. These can be structural or functional issues. I have some examples of that on the next slides. But basically, it impairs the way that it is filling and or ejecting blood. Okay. These are progressive. You'll see that on the next slide. The way that these do progress are dependent on if they're treated, if they're able to be treated, compensatory mechanisms, if it's medicated, if the patient's following through, and it starts at minimal impairment, they might not even really notice, all the way up to it is affecting every aspect of their life. Okay. So depending on the stage that they're in, the side of the heart that it's affecting, and just the severity of it, symptoms that you are going to see could be pulmonary or systemic congestion of fluid. These can also be systolic, and this is going to be determined by their ejection fraction. So I think we talked about that in patho, that ejection fraction is something that's measured in heart failure that basically says how effectively how the pump is able to eject blood. And so if that is impaired, if that's decreased, then that is a measurement of the severity of it. Okay. So in systolic, that's going to be the ejection fraction less than 40, and normal is like 55 to 70. Okay. And then for diastolic, the issue there is with ventricular filling, and it can be either or both. These aren't necessarily things that you need to know for this class, but because you're not covering this in another class, I need y'all to have a little bit of background so y'all know what we're treating. Okay. So here are the classifications of that. The classes are basically based on how this is affecting their activities of daily living. Okay. So class 1, like I said, there's really no impairment. They're compensating. They're able to live a normal life, all the way up to they're going to have symptoms whether sitting around not doing anything or whether they're up and moving. Okay. So as it progresses, that is affecting their quality of life, affecting their ability to care for themselves, and obviously going to be more impactful. So this is just a slide going over how contractions work. Um, Basically, what I'm just going to point out here, that our heart contracting is reliant on calcium, oxygen, glucose, and ATP. Okay. As far as the function, if function is an issue, then drugs can target that specifically in order to affect contractility. Okay. We know that calcium plays a role in our heart's contraction, so there are drugs that are going to affect calcium. All right. So just based on that, whatever the person has going on, the drugs are going to target that specific part of contractility. Okay. Whatever's controlling that. So all of these things listed here are some causes of heart failure. So coronary artery disease, which can lead to decreased perfusion, which leads to weakness, ischemia, and cardiac damage. Okay. That is going to put them at risk for an MI. Cardiomyopathy, this is just a disease of the heart muscle itself. It impairs contractility and function. This could be due to viral infections, alcoholism, abuse of steroids, some genetic anomaly. They could be just born with that. Hypertension is another cause. Just that chronic pressure makes the heart work harder, and it gets overworked is basically the gist there, okay? And so that can lead to hypertrophy, and then vascular or valvular heart disease is going to increase the workload on the heart as well, make the valves not be able to close properly, and builds up in congestion, okay? So, depending on what the cause is, obviously, if this is genetic versus if this is high blood pressure issues, we're going to give medications that target whatever the cause is. Okay. And if we can treat the cause or treat the complications of the cause, then we treat the heart failure. All right. So our body tries to compensate by these mechanisms. And so, like I said, at first, your body recognizes there's a problem. It implements this compensatory mechanisms, and you may not have symptoms at first. What happens is that leads to overwork, right? Eventually it gets tired, and then the heart failure starts to present. So, because we have decreased cardiac output, it stimulates that our sympathetic nervous system, which leads to the release of those catecholamines, which leads to increased contractility, and then renin is released due to the decreased cardiac output. Okay, and so that is what ultimately ends up with causing fluid retention. Again, these are just normal things that occur. And then if, for one, they don't work right, or if we don't do something to treat the problem, that's just going to get worse. Okay. Um, this does lead to, over time, that worsening. There's a chart on page 772 if y'all want to look at this. I'm not really going any deeper into that. Just it gets worse. Okay. And then I have a note here. There's a picture on 773. It could be this picture. I'm not 100% sure, of just showing what heart failure looks like. So for left-sided heart failure, you're going to see pulmonary manifestations. So they might be short of breath. A common thing that people talk about is like a tripod position. You might see them leaning over like on a bed rail just trying to breathe. They may have orthopnea where like if they're lying down they can't breathe. If they sit up they can breathe better. They may be tachypnic. When people think of heart failure, they think of crackles. So I have this accumulation of fluid, and when you auscultate somebody's lungs, you may hear crackles in their lungs. Okay. They could have hemoptysis where they're coughing up blood, and they can have pulmonary edema. Right-sided heart failure is more systemic, okay? So that's where I'm going to see systemic or peripheral edema. They may be fatigued, they may have weight gain, they can have enlarged spleen, enlarged liver. They could have nausea or abdominal pain, and then they'll also have nocturia. So basically, when they lay down at night, that fluid that has accumulated is able to be processed and they have to go pee. Okay, so that can be something that is a manifestation of that. Now, as far as distinguishing these things, it is helpful to know if what side is affected, what the signs and symptoms are going to be. But I do want you to understand that if one side isn't working the way that it's supposed to and that isn't treated, eventually both sides are going to be affected. So in the cases of patients that I've taken care of where they're coming into the hospital like for an exacerbation, most of the times you're seeing both of these things. It can affect both sides, okay? So that can lead to abnormal heart sounds, cardiomegaly, and like I said before, just an inability of them to care for themselves. They're going to get up and they're out of breath. Obviously, that's going to impact them being able to do whatever, which leads to a lot of other complications. So treating this early is going to be important. So as far as assessment, let's just stop here because I sometimes get way deep off into the woods, and I think it's good to just think about this for a second. If a patient has heart failure, what assessments specifically would I want to do? JVD, very good. What'd you say? Edema. Have y'all talked about edema yet? Pitting edema, right? So I'm going to look just to see if I see that if it's symmetrical, right? Is it one-sided? Is it both sides? Is there some other reason? If I look at your leg and your right leg's swollen and your left leg isn't, and I'm am I immediately going to say they must have heart failure? No, right? I because probably an indication of that is you have some sort of venous issue, or you have maybe you've sprained your ankle, right? Like that would make sense why that would be swollen. But this is more like a profuse swelling. So I'm looking at that. I'm checking for pitting edema. I'm looking for the degree of it. What else? If this can lead to fluid accumulation, what else might I do? Okay, I want to see if they're short of breath. I want to listen to their lung sounds to see if I hear that fluid. What else? Weight gain. So one of the common things that we teach people, we do this in the hospital, but also we teach people when they go home that they need to weigh themselves every day, same time of day, wearing relatively the same type of clothing. And if they notice a weight gain, that they may need extra treatment, right? What else? How do I get rid of fluid? I pee, right? So eyes and nose. I want to know, are they going to the bathroom more regularly? What else, based off of something I've said today, what I might want to ask them about going to the bathroom at night, right? Are they able to lie flat when they lay down? Those are all things that I would want to know, and that's specific to heart failure, okay? So if I'm giving them medication for heart failure and it's affecting one of those things that I said could cause it, what would I expect their response to be? If I'm giving them medicine to treat it and I'm asked all these questions, what would I expect? They're peeing. They're not swollen. They don't have crackles. They don't have to go to the bathroom at night. They can lay flat. That would be an expected finding. Those are the outcomes that I want to happen. So if I'm giving somebody one of these medications and they're experiencing those things, it ain't working, right? And maybe they need other meds, or maybe they need a different med, or maybe they need an increased dose, but it's not working. So that would be me monitoring if this medication is working. I think I talked about this at the very beginning. What would be negative? If let's just say I'm equating heart failure with too much fluid and I'm giving them medication to treat that, what would be a negative thing that can happen? Dehydration, right? Because they got fluid retention. If I'm saying that's the problem, if I overcorrect it, now they have too little fluid. What is too little fluid going to look like? Okay, that is potential. What else? Low urine output. What about blood pressure? It's going to be low if I have depleted their fluid, right? So that makes sense to us. If I'm giving these medications to treat that, those are things that I'm going to be concerned about, okay? If so I just want y'all to think about that big picture. Now, all the things we're going to talk about are going to some degree affect that. We're going to get into more specifics, but all of those things remain true. Okay? Yes.
So, if you give good and time frame Do you hydrate them and then?
That can be very tricky. So it really just depends to the degree. Like if they took 4 of a Lasix where they were only supposed to take 1, that is going to be a lot more severe than something that may be more easily corrected where we're just allowing that to work out. You know what I mean? That really is, and the severity of their heart failure, I would say. But most of the time in the hospital, when we're doing fluid replacement, you're talking about IV fluids. And so if their heart can't process fluid the way that it's supposed to, if I go give them IV fluids, I've just complicated their condition. And so I would just say you have to be very careful. I don't even want to get into specifics about it. Um, you could do fluid replacement. You would just have to be very careful with that and a much lower rate, like where for you I may give you a bolus, like we might quickly do that. For somebody with heart failure, you may do that more conservatively. And so it really just depends on the situation. Most of the time that isn't a concern, but that is a concern, especially with people at home treating themselves. Um, but very good question. I would just say be conservative. And then one of the most important things is if I've given you too much and now that's my problem, what would be the most important thing for me not to do? To give you more of it, right? So I would hold the next dose and then a provider would make a decision on what we're going to do in the meantime. But then that can get tricky because they still have the problem. So they may use a different drug targeting some other part of contractility versus just removing fluid, if that makes sense. Okay. Um, all right. So on that note, I have a note here that on page 774, there's a picture going over the algorithm for treating heart failure. Um, so we start at stage A. The first thing that we're going to do is we are going to adjust the risk factors for heart failure. Okay. The ultimate goal there is to reduce the workload on the heart. Stage B, we will give them beta blockers and things that affect the RAAS. Okay. Um, the beta blockers are going to affect those things that stimulate the sympathetic nervous system, which are going to make the heart not have to work as hard. And then RAAS, same thing. It's getting rid of that excess fluid that it's having to manage. Okay. Um, or stopping that process, I guess. Stage C, this is where those two things haven't worked, and so now they're having to add additional medications. Okay. Um, so in these, especially once you get to that later stage, their kidney function is going to play a bigger role in making the decisions on what medications that they're prescribed. And we'll get into that more specifically when we go over the different medications. And then once they've graduated to the final stage of that or the more advanced stage of that, they may have to have a ventricular access device, which actually makes their ventricles contract, a transplant, or they may even just be on palliative care. So we try to do the least impactful things at first, okay? And just the goal of the beginning of treatment is to decrease the workload and oxygen consumption of the heart. All right. And so the goal there is, I think I just said what the goal is, but we want to slow the progression. That is our aim with that. So if they're compliant with treatment, the goal is to just slow that down to prevent them from having to get on other types of medications because that means that it is progressing. Okay. This is just a picture of that algorithm. This could be what I pointed out to y'all in the book. Again, I'll go over these specific medicines once we start getting into the medications themselves. But I did just want to point out that for the decisions that they're making, kidney function is playing a role in that, okay? Because that is affecting fluid. And so their kidney's ability to process is going to play a role in the medications that we choose. All right. That's basically what I want to say about that. All right. So I have a note here that on page 776 and 777, there is a chart and a table, and this chart is the one on 777 of where these medications are acting. So for cardiac glycosides, those are going to increase contractility by affecting the sodium-potassium pump, which increase calcium levels. Phosphodiesterase inhibitors, those are enhancing the calcium for contractility. And then calcium channel blockers do that, which affect the heart rate and contractility. And then the neurohormonal modulators, those are blocking the activation of those things. Okay. And again, that'll make more sense as we talk about those specifically. All right. So first, we are going to talk about cardiac glycosides. These medications are used for heart failure when other medications fail. So the main one that we are going to discuss is digoxin. This is used to treat AFib, A-flutter, and CHF. So we will circle back to this when we talk about arrhythmias. It is affecting that sodium potassium pump. And I've tried to go in and add these pictures for y'all because I feel like these slides can get wordy and an abundance of information. So I feel like this does a good job of, yes, just making it more concise and hitting the high points. Okay. So if there are things on other slides that I want to tell you, I will, but I do think this does a good job of providing an overview. So for heart failure, I just want to point out this is not the first line treatment. Okay, this is when ACE inhibitors or other things that affect the RAS and beta blockers didn't help. Okay, so this is later on to treat heart failure. These are contraindicated in ventricular fibrillation. I will go over that again when we talk about arrhythmias. And then common side effects, they may be fatigued, have anxiety, hallucination. One of the biggest things with digoxin, it is one of those drugs that you have to monitor a therapeutic drug level. So toxicity is a concern with digoxin. They may have visual disturbances, so they can see like a yellow halo around a light. And that is one of those things I remember when I was in nursing school learning about digoxin, and that sounded crazy to me, first of all, because I've never heard anybody say that. And so I'm like, I am going to remember the yellow halo over the light. So that is something that can occur. And that is something that you may see on a test just because it's weird, right? It's something that you can pick out. But in real life, when somebody has dig toxicity, nausea, vomiting is a big deal. That is something that you are like, I'm aware that this is a potential that they have dig toxicity. Okay. Other things that can occur because this can help with uh, arrhythmias, it also can cause them because it can affect your rhythm. Okay. Electrolyte imbalances are very important for me to monitor. I'll talk about that on a couple of next slides. And then other medications. There will be a lot of medications that we talk about that can interact with digoxin, even in this chapter. I feel like there's something. Oh, before we move on, if there is a therapeutic drug level for this drug and there is a potential for toxicity, before I go give this drug, what do I need to know? The drug level. That number one, right? I need to assess my patient and I need to know what their drug level is. Okay. After I give this, what would I want to know? Look at you. Yes. And the side effects. And I'd also want to know the drug level, right? I gave it. I've given it and I need to know. I do need to know the peak and the half-life so that I know when to expect this to make a difference. But yes, I need to know that it's within the correct range and look for these side effects. Okay. All right. So again, digoxin is inhibiting the sodium potassium pump, which increases intracellular sodium, which increases intracellular calcium, which allows for stronger contraction, which causes a positive inotropic effect. Okay, it's increasing contractility. So before we move past that, did I say that this is first line for heart failure? No, because what did I say, if you recall? The first thing we want to do for heart failure, decrease the workload. So if I'm increasing the contractility, am I decreasing the workload? I'm not. I decreased the workload. I tried that. It couldn't compete with that. So now I got to make it actually work. Okay? So this is later on. This can lead to an increase in cardiac output, which leads to increased renal blood flow and increased urine production. So it can have somewhat of a diuretic effect. The ultimate goal here is improving the cardiac output. And then trying to see if I want to even go there. I guess I'll say that. So once I've increased the urine output, I have triggered my body to say, okay, we don't need more renin, right? So it's stopping the RAAS, which is further helping my heart not to have to work as hard. So slows heart rate and that's not right. Slows heart rate and increases contractility. Okay, that is our main goal here. All right, so again, times where I'm using this: heart failure, AFib, aflutter, or paroxysmal, which just means comes and goes, atrial tachycardia. So when I am given this medication, if it is affecting their heart rate and affecting their rhythm, what I say it's doing to the heart rate? Decreasing the heart rate, and I'm affecting their heart rhythm. What do you think I want to know? Heart rate and their rhythm, right? So especially when you're first giving this medication, they would probably need to be on some sort of cardiac monitoring, okay? And then if I suspect that they have toxicity or some other sort of issue, then we may get an EKG or put them on cardiac monitoring. I'm also monitoring for those signs and symptoms of toxicity, their renal function, if they're able to have that increased urine output, their electrolyte levels, especially potassium, their digoxin level, and just looking for those signs of toxicity. Another thing, and I think this is on another slide, but I do just want to say it. This is one of those medications, this and beta blockers are medications you want to assess an apical heart rate for a full minute, and I am going to hold this medication if it's less than 60, okay? I don't need to decrease it any further. If they have renal issues, there is a potential that it can't be excreted, and that is going to increase the risk for it to making it be toxic, them to have toxicity issues. So contraindications for digoxin, if they're allergic to it, if they have VTAC or VFib, if they have heart block, if they're having an acute MI, renal insufficiency, or if they have a high calcium, low potassium or low magnesium. I also, unless benefit outweighs the risk, we're not giving this to pregnant or lactating people. This isn't specific to digoxin, and I wanted to move this, but I'd already published this for you, so I'm going to just go over what I want you to know on this slide. But this is just for heart failure treatment in general. This is on page 776. Just make sure that you double check your dose with another nurse, especially for digoxin, and make sure that that is falling within the therapeutic window. Monitor for signs and symptoms of dig toxicity, and then for kids specifically, ivabradine is a drug that can be given for cardiomyopathy. And then for adults, and this is really just for anybody taking this medication, I want to teach them to monitor for those signs and symptoms of heart failure. Okay. If it's worsening, if it's getting better, or just specific side effects of the medications. And again, with the elderly, some of these may be contraindicated or they may need adjusted doses. All right. Back to digoxin. So our therapeutic window here is 0.05 nanograms per milliliter to 2 nanograms per milliliter. And this statement says that if the levels are less than 0.05, it's not going to work. It's not going to be helpful. And if it's greater than 2, it's risk for toxicity. That is very narrow. Okay, so teaching patients signs and symptoms or why they're in the hospital, you monitoring that will be very important. So again, signs and symptoms, there are just regular signs and symptoms, and then toxicity, the vision changes, those yellow halos, the nausea, vomiting, or arrhythmias, including heart block, atrial arrhythmias, and VTAC. Which is, again, if this can cause heart block, is why I wouldn't want to give it if somebody has that. If they have low potassium, they are going to be at risk for dig toxicity. Okay, so knowing, in addition to monitoring digoxin levels, I'm monitoring potassium levels as well. So hypokalemia increases the risk of arrhythmias. This is a drug that has an antidote. So you may see if somebody has dig toxicity or digitalis toxicity, the drugs that are used to treat that are Digifab. I added these, Digibind, or we also can give lidocaine to treat VTAC. Okay. For children, I do have that specifically, that the first sign is nausea, vomiting, and fatigue. If it is very high, that can lead to hyperkalemia. All right. Here are some drug interactions. As you can see, yes. Here's some drug interactions. As you can see, there are lots of different ones of these. I'm not getting too specific. Potassium is very important. And then potassium sparing diuretics, potassium losing diuretics, because they are making me lose potassium, is going to be one of the most important ones. Okay. So if I'm giving digoxin and Lasix together, it's going to be extra important for me to give potassium. Okay. And to monitor that level. It is contraindicated to take this with licorice, and to tell you the truth, I knew that and I don't remember what the issue is, but it has some interaction with it. So even somebody eating that like candy, that could be an issue. And then if they're taking things like binding type medications, uh, cholecystiramine, which we will talk about that for cholesterol treatment, antacids, charcoal, those medications need to be separated, like 2 to 4 hours from giving digoxin. Okay. All right. And then just other on that note, if there are if any of those medications are causing a decreased heart rate, if I'm giving something like digoxin that's decreasing the heart rate, or if I'm giving medications that are affecting their heart rhythm, that's going to increase the risk for bradycardia or arrhythmias. Okay. All right, so here's the drug card from your book. This is on page 781. The only thing additionally that I wanted to point out here is that they may need a loading dose. Do y'all remember what a loading dose is? At first. It kind of at first. So at first, when I give you this, I might give you a higher dose, and then once I've established that, they'll give them a decreased dose for maintenance beyond that. Okay, easiest way to describe that. Yes. Okay.
It lowers it, I like peak sodium ion potassium and blocking that so it's keeping you sodium. How's it gonna make you hurt?
Let me think of this. Sodium, potassium for stopping. So the let me just say, for starters, that the biggest issue is we're treating, well, digoxin can treat arrhythmias, right? And if it can treat arrhythmias, it can cause arrhythmias. Hypokalemia can also cause arrhythmias. So those medications together, or excuse me, taking digoxin with a condition that can cause arrhythmias increases that. Let me get back to you once I have had time to process that information, and I will tell you that. Because that is a very good point, and I can't, do you
That's
know?
a big thought.
It is. Yes, yes. That is a lovely thought, and I love the way that your brain works. In fact, I'm writing this down. And so many of these things, I haven't thought about it to the degree that I want y'all to understand it until I'm getting ready to teach it. And I'm like, yes, I'm going to make them understand this because I feel like if you do, it makes so much more sense. And then I get ready to teach it, and I'm like, oh wait, hold on, let's go back. Let me think of this because this made sense to me 20 minutes ago, you know. But that is a wonderful question. I will come back to you on that. And then I put these up here just again. I feel like this would be helpful to you. So I want to let me see if there's anything else I want to point out here. Um, we have our antidote. Make sure you check the pulse, hold it. And then I don't know that y'all talked about this yet, so I do want to point this out. It is our responsibility. If something is contraindicated, I don't care if they have 14 stat orders. If it is contraindicated and I do not feel safe to go give this to this patient, I'm not going to. That is my job. I should not. But I can't just say, I'm not going to give it and go on with my life. I need to call the doctor, right? And say, you've ordered this, this, this. I don't feel comfortable because this. What do you want to do? Okay. So I do want to point out I'm holding it, but I do need to let the doctor know that I've done that and why. Okay. Um, and then the hypokalemia can increase the dig toxicity. Um, we're looking for our side effects of that. We've already talked about that. That's really it. So maybe these will be helpful to you, just kind of everything there together. Is this helpful? The little things? Okay, great. All right. So true or false? The first goal of treatment for heart failure is to make the heart beat harder and faster. That's false. Very good. Okay. Next, we're moving on to phosphodiesterase 3 inhibitors. Okay. So these are inotropic. I'm trying to just tell you what I want you to know. Milrinone is the only phosphodiesterase 3 inhibitor. You might also see this just PDE3. And it is used for short-term treatment of severe heart failure that has responded poorly or has not responded to digoxin, diuretics, and vasodilators. Okay, it is inotropic. I'm trying to think of what I want to tell you about this. It blocks phosphodiesterase and myocardial CAMP, which increases calcium in the cell, which makes for a stronger contraction. Prolonged sympathetic stimulation leads to vasodilation. It could cause arrhythmias. Okay, here is our little card for that. This now I want y'all to pay close attention to. I added this because these are things that y'all are going to be talking about, or I may even be referring to these as like contraindications or medications that can interfere with this. But all of these medications are not indicated for heart failure. Okay, so just this is PDE5, this is PDE4, and this is PDE3. Okay, PDE3 is what we are talking about for heart failure. But these may be helpful for you to look back at for how that is, or how those medications work or what they are. So the PDE3s can be used to treat ventricular arrhythmias, headaches, or hypotension. These PDE5s, we're not getting into this. This has nothing to do with heart failure. But those are medications like Viagra that can treat erectile dysfunction, and those can be contraindicated in cardiac patients. Okay. That's the end of that. One of the biggest things I want you to know about milrinone is that it is contraindicated in active MI because it increases cardiac contractility and oxygen demand, which is worsening the myocardial damage. Okay. Also contraindicated in severe aortic or pulmonic disease. The fluid volume deficit could be worsened because renal perfusion is increasing, and then this also can exacerbate ventricular arrhythmias. It is given only by IV, and older adults are at an increased risk for adverse effects. Adverse effects of these are potentially fatal ventricular arrhythmias such as torsades, hypotension, and chest pain. So also angina, MIs, contraindicated. Can have nausea, vomiting, abdominal discomfort, thrombocytopenia. So we need to make sure we're monitoring platelet counts. They can have burning at the IV site and could potentially develop vasculitis, pleuritis, or ascites. So those are things we're just teaching our patients to report. And because this is given by an IV, you're going to be monitoring these things if you're who is administering it. So make sure that you do an assessment on your patient, monitor for those adverse effects, make sure that they don't have any of the contraindications. We want to know heart rate, blood pressure, rhythms, a baseline of vitals, fluid status, electrolyte levels, and we're looking for those adverse effects. Also, big deal here, it can precipitate, which there are different things that can occur, but I usually just describe that as like crystallization can happen in the IV line if that is given in an IV with furosemide. So if they're getting IV Lasix and they're getting IV Milrinone, then it needs to be either given in different IVs or make sure that you flush properly and not given them at the same time. I have seen this happen. I don't know that y'all have learned this yet, and I want to tell y'all just in case nobody else does, but when you're giving IV medications, you need to check compatibility. This is a thing that can occur. So when you go, whatever medicine that you're giving, I usually just Google it if I'm being honest, but I'm sure that the electronic health records have something that you can click on that shows it. But there are charts that show compatibility, and you literally go find the medication you're giving, and it shows what it is incompatible with. Okay. Antibiotics are common things that have issues with that. But I've seen this happen. I don't know that I checked the compatibility, if I'm being 100% honest. Maybe I had just thought it was fine, or I did and it was good. I really can't remember the situation, but I thank God the person had like an IV line of medication. I think actually maybe something was just still in their line and I didn't know. But either way, I went to go push the medication, and you could tell it looked bad. It looked like, yeah, I don't think I'm going to put that through their veins. Yes, it as soon as it happens, you could tell that it mixed, and it was like it did not look good. And so, thank God that was in somebody's IV line, and so it didn't go to them, because that's also whatever's happening in that line would have happened in their veins. So check compatibility first. Okay. Here's our drug card for that. This is on page 784. This does require continuous cardiac monitoring. It has positive inotropic and vasodilatory effects. So if I am vasodilating, what would I expect to see? A lower blood pressure, which means if this person has to get up, they're going to be at risk for falls. So monitoring their vital signs, monitoring their heart rate is going to be very important for me to do. And again, we're looking for pain at the injection site, phlebitis, that could be an issue, or arrhythmias and platelet count. Okay. Next, we're moving to HCN channel blockers. Avabradine is the drug that we are going to talk about here. All right, for these work by slowing the heart rate without reducing the contractility. Okay, so the heart is contracting the way that it has been. It's just slowing it down, allowing it to not be overloaded. Okay. So it is impacting cardiac workload. So we have a decreased heart rate with these medications. If my heart rate is decreasing, what do I need to know before I give it? The heart rate, and I'm monitoring that afterwards. Okay. I think that's all I want to say about that. Okay. So this is indicated for patients who have stable symptomatic chronic heart failure, but their ejection fraction is less than 35, or who they have a consistent heart rate over 70 and they're on the max dose of beta blockers, because beta blockers are also going to decrease their heart rate. Yes.
Is this the second, like you give it after?
Correct. Yes. Good question. Again, if in the future I feel like this should be reorganized of like what are we doing first, but we'll keep you on your toes for now. So this is for decompensated heart failure. It is excuse me. We're contraindicated in decompensated heart failure, hypotension, sick sinus syndrome, or if somebody has a pacemaker. Okay. And again, if they have bradycardia already, I don't want to go slowing their heart rate down. I do not want to give these to people who are pregnant, And these are less common medications that are given. So some of these, if I'm briefly going over them, they just aren't given commonly. And I think that our efforts could be focused elsewhere. Okay? Um,
Right, has to do with it's something that has contractibilities.
Force. Yes.
The the rate is more affected by like the electrical output of the heart, whereas the contractility is going to be the force that it uses to squeeze. So you can change one without changing the other.
I don't understand what you're saying.
And if you, it really is just helpful. Those pictures in your book, I know that that is aggravating and y'all already have a lot to do, but seeing what part of the heart that it is affecting, like what phase are being effective, really does do a better job of saying, how is this going to help over certain things, if that makes sense. Probably digoxin. I mean, that I want y'all to be able to recognize the drugs specifically. Um, I don't want to say a steadfast thing, but I would say more specifically the drugs themselves, or like recognizing it falls into that category, but that's the medication that you're going to see. That's what you would be giving. And so even on tests, that's what you're going to see of making those decisions based off of the drug itself. Um, the One of the biggest concerns with these medications are visual concerns. So, or with Avabradine is visual concerns. So it can have an issue of like the way light is interpreted or made them see multiple images. So falls would be a concern with these patients. Bradycardia, hypertension, and AFib are other common side effects for this. And I have a note here that the nursing considerations chart is on page 785 or 786. And then if you're giving other drugs that are slowing down the heart rate, that's going to increase their risk for bradycardia. All right, so here is the drug card for that. The goal in treatment is to make their heart rate be somewhere between 50 and 60, just so it's not having to work as hard. All right, next, what time is it? We can finish. All right. So next we're moving on to angiotensin receptor neprilysin inhibitors, or ARNI inhibitor. Our drug here is Entresto. And I liked this little thing just to show how this is helping. Okay. So natriuretic peptides help balance our salt and our water. Okay. If fluid is an issue in heart failure, managing the salt and water would be helpful, right? So that's the goal of natriuretic peptides. Neprilysin breaks down those so they can't work the way that they are supposed to. And then, pause that thought, angiotensin 2 causes vasoconstriction, increases aldosterone, which leads to high blood pressure. Okay? This medication is a combination of sacubitril, which is inhibiting those that are inhibiting the natriuretic peptides, and then valsartan is blocking the angiotensin 2. Okay, so those drugs are going to help my natriuretic peptides do what they're supposed to do, and it is making the blood pressure not be high. Okay, in a nutshell. Um, okay. So, Entresto is the drug that falls in this category, which is combining valsartan, which is an ARB, and sacubitril. And it is better in patients who have, or it's better than patients taking ACE inhibitors alone. That's basically that. Okay. I'm trying to see if there is. Oh, so this drug specifically was developed to reduce hospitalizations and risk for cardiovascular death in patients who have chronic heart failure and reduced ejection fraction. It also can be used in patients, pediatric patients, when they have something wrong with their left ventricle. That's that. We're skipping this. I've said what it was for. Okay. Okay. Neprilysin.
That that's a mess of so you're giving the S drug levitazole to balance the salt in the
The fluid. Yes.
whatever that valsartan to increase the salt in water.
No. It's that handles your blood pressure. So that's an ARB. That's one of those drugs we talked about for your blood pressure. So that is handling the fluid balance, or that is handling it's handling your blood pressure. It is annoying. Think about them separately. I think is easier to do. Of remembering as them as two different things. Yeah, natriuretic peptides are what we need for the balance. Neprilysin breaks that down. I don't want it to break down. I need it to deal with the water balance. And so the sacubitril is affecting that. It's helping it not break it down. Yes. Okay. So we've already learned about ARBs, okay? So the easy part of this is if it has an ARB in it, everything that is contraindicated in that is going to be the same. The side effects are going to be the same because it contains that drug, okay? So this is going to be contraindicated if anybody has taken one of those drugs, like an ACE inhibitor or an ARB, and had angioedema as a result of that. This is contraindicated. Okay. If they are pregnant, if they have renal impairment, this drug is contraindicated. While they're taking it, I'm monitoring their renal function, monitoring their blood pressure, monitoring their fluid balance, their output, potassium levels, as well as angioedema. So side effects that can occur are hyperkalemia, hypotension, cough, dizziness, and renal impairment. So we usually start them at a lower dose. All right. Drugs that can cause an interaction with this are ACE inhibitors, potassium sparing drugs, lithium, and nephrotoxic medications, which include NSAIDs. All right, so your information for this is on page 787 and 788. We usually do start them on a lower dose with these, especially if they're not on an ACE inhibitor or an ARB. And then if they do have kidney issues and it's decided that they need this, then they'll be on a reduced dose, okay? Again, we're monitoring blood pressure output, potassium levels, and angioedema. Fun times. Okay, so a patient with a history of digoxin adverse reactions and heart failure presents to the emergency room with acute MI symptoms. Which of the following medications would be concerning? Milrinone. Yay. Yes, we are not giving that to them. Okay. Remember that Milrinone is contraindicated with acute MI because it's increasing contractility and workload. Now,